Okay, so we're continuing with the autonomic nervous system and basically the structures, what role it plays, and yeah, basically we're dealing with again the peripheral nervous system bringing sensory information to the central nervous system, and then the central nervous system processing, integrating all of that information, and then eliciting some sort of response. So we we've known this. This is how, yeah, again, negative feedback. We're giving that constant sensory to the integration center, and generally the response is that we want to oppose the stimulus. So that's that negative feedback. If we're getting too much glucose in the blood, that signal is going to get sent to the brain. The brain's going to say, all right, well, let's trigger more insulin to get released, and let's vasodilate some areas and get the ball rolling. So that's going to be again your negative feedback. Your effector aspect is also seen as the feedback. So I suppose that's a really good way of looking at it. Yeah, is the effector or the effect that the body is expressing is going to be related to the feedback. And again, negative feedback is so the negative part is what's we're opposing the stimulus. So stimulus is blood sugar's too high. The response is we want to oppose the stimulus of high blood sugar. So we're going to try to get the blood sugar lowered or decreased. Maybe the blood sugar's too low. We're in between meals. That's another trigger, another stimulus. The response is going to be negative feedback. We want to oppose the lack of blood glucose. So we're going to trigger storages of glucose to get released, and then deliver all of that to the cells. So, and then the stimulus comes back to the brain and says, yep, we're good to go. Let's just kind of keep it calm, or let everything level. Okay, so that's really, yeah, the name of the game for advanced AMP is going through negative feedback, positive feedback, homeostatic mechanisms, and primarily how they relate to the autonomic nervous system with that endocrine system at the very top, and then the trickle down and the connecting branches to all of the other body systems that will. And again, that's what we see in advance. So I'm not going to spend a heck of a lot of time. I probably already spent too much time, but so anyway, just remember we have two autonomic divisions. One is going to be your rest and digest, they call it, more or less kind of your homeostatic maintenance. That's that parasympathetic division. Now, when we do perceive some sort of a stressor, whether it's an external stimulus, whether it's an internal stimulus like inflammation or something like that, or like we said, low blood sugar, that can lead to kind of a breach in homeostasis and trigger something we would call a stress response. That's going to be the sympathetic nervous system pathway. So when we need to increase the heart rate, increase blood pressure, increase adrenaline or epinephrine. We need cortisol increase. We see respiration rate go up. Anyway, all of these things going up in response to the stimulus, whatever it might be. Again, it could be an external stimulus. It could be something internal. Typically, if it's an internal stimulus, it's going to relate to some sort of inflammatory response. So an inflammation exists due to any number of things. Usually it's an infection of some sort, or repetitive use or overuse, or maybe an acute injury. So any like internal pings that are hitting the brain and that sensory pathway of the autonomic nervous system may be related to inflammation. And so the brain's response, again, negative feedback. It wants to promote anti-inflammation principles. And so we're going to get a cascade of different chemicals and antihistamines and all kinds of other items released. So that's, again, those are more physiological concepts. But I think in order to get some of the basics of what's going on with the autonomic nervous system right now, it's good to give you a couple of examples. So anyway, yeah, sympathetic, that's your stress system. It's your body's normal response to stressors. And again, stress is probably one of the biggest commodities we see coming through the clinic. It's why everybody comes in. It's hypertension, chronic pain, acid reflux, asthma, COPDs, metabolic disease, kidney malfunction, type 2 diabetes. The list goes on. These are almost 100% related to inflammation, and that inflammation is due to chronic stress. It's chronic inflammation due to chronic stress. We've talked about set points in the past. We'll talk about them some more next semester. But again, these sympathetic responses are supposed to be available in an as needed fashion. And again, some and maybe many, I shouldn't say some, most probably of our patients are in our office because they are under some sort of chronic stress. Now, again, if it's physical stress, we try to help them with bracing, with splinting, with gait, with certainly pain management, with a multitude of other aspects for the musculoskeletal for musculoskeletal issues. Now, either way, it's stress, right? It's inflammation, and again, we also have mental and emotional stress perceptions and memories and post-traumatic stressors that again have triggered the sympathetic nervous system to be in the driver's seat. And when the sympathetic division of the autonomic nervous system is in the driver's seat, we're talking about a lot of anxiety, a lot of heart issues, cardiac palpitations. We're talking about respiratory problems and a whole slew of other gastrointestinal issues as well. So, what are we doing in the clinic? We're trying to understand how we can enable the patient to enable themselves to have better boundaries, better coping skills, better lifestyles, and in the meantime, we can help them with some of their inflammatory aspects. And there's certain things that we're just not qualified to help them with as well, but we can certainly try to address some of the symptoms that they're coming in with, and hopefully try to establish some better homeostasis and ultimately get that sympathetic nervous system calmed down and engage the parasympathetic system to be more in control. So that is what's happening with the autonomic nervous system. This is a little nice diagram. It may seem a little tedious at the beginning, but if we break it down, we see everything we've already discussed. We see the central nervous system up here being represented as this rectangular kind of three-dimensional type deal. And then the peripheral nervous system, your cranial and spinal nerves outside of that central kind of boxy cube deal. I guess not a cube, a rectangular item. And then within that is the autonomic nervous system and its integration centers. So again, autonomic integration simply means that the brain and spinal cord are processing, they're receiving and sending out. It's receiving stimuli and sending out responses. And again, that's all going on. We saw when we looked at the brain, we looked at the medulla, we looked at the pons, the brain stem, the diencephalon. Those areas, those primitive areas of the brain, are where a lot of our autonomic integration centers are located, right? So I think you'll probably recall that from a couple of discussions ago. So what this is showing is, so down here are the nerve pathways. So it's just showing that we have this sensory pathway, this afferent division bringing in stimuli. This particular one is showing visceral receptors. So visceral meaning inside of the body. And then these visceral receptors are bringing stimuli. And again, oftentimes it relates to blood glucose levels, blood calcium levels, pressure, what we call receptors, or pressure, blood pressure receptors. So anyway, a multitude of different inflammatory receptors. When we have excess amounts of fluid in a tissue compartment, visceral receptors will pick that information up and send that up to the brain and spinal cord, and mainly we're going to go to, again, that brain stem and up into the diencephalon, and kind of try to regulate some of our fluid levels and maybe trigger some anti-inflammatory chemicals. So that's what we have over here, are the two pathways of autonomic efferent path, the sympathetic and parasympathetic divisions. Again, the sympathetic is going to trigger a lot of this. We're going to see vasodilation. In other words, blood vessels increase in diameter in some areas. We're going to see vasoconstriction occur in other areas. We're going to see the heart rate increase. We're going to see respiration rate increase, body temperature increase. We're going to see ADH, or antidiuretic hormone, increase so we can retain fluids. We're going to see cortisol and some of these stress hormones get released to help prevent some of that inflammation. So again, that's kind of there and available for, when you're cruising down the road and somebody pulls out in front of you and you have to react or respond, or you're out in the woods on a hike and, noise in the woods. And again, guy in a Yeti suit, or a cougar or a bear, I don't know, either way, I'm getting out of, so that's when that superhuman kind of awareness and strength, pupils dilate really big. I mean, so sensory gets really acute. So that's as needed, and then everything calms down, the traffic breaks up, and the election's over, and that was a guy in a Yeti suit. It really wasn't a Sasquatch, which I mean, I don't know. I'd maybe preferred to have seen the actual Yeti or Bigfoot than the guy in the Bigfoot suit, but maybe not. I don't know. But either that's still right. That's woohoo, got my camera, right? I mean, so there's good stress, right? We're getting ready to go to Disney. We've got to get the plans. We've got to make sure all the everything's in its place, and ducks are in rows, and I guess maybe mice in rows if you're going to Disney or whatever, right? But there's ducks too, right? Donald and Daisy. So everything's got to be lined up. We've got all the plans. Do we have the money? Do we have the funds? Are the kids, everything, just go. And then you get there. That's before you've even left the house. That's months maybe, right? Oh, the big vacation. Then you finally get to the vacation, and yeah, it's go 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 go. It's straight. You need a week or two off just to come down from all of that. So that's, again, sympathetic exercise, right? I'm gonna head out to the gym, peak fitness, and hop on the treadmill and, do some stair climber, maybe pump some iron and do some whatevers. And, that's causing me to sweat. It's causing my heart rate to go up. That's the definition of a sympathetic response. That's good. We're prepping, right? You don't want it to be completely asleep when you do need it. So, but anyway, once the bear's done chasing us, we need to get back to normal. So that's when the parasympathetics going to kick in and kind of bring everything back to level. You're going to be really hungry. That's why they call it rest and digest. You're going to be ready to take a big nap, or probably eat and then nap. I think that's really, turkey. They talk about turkey and tryptophan, right? And you eat the turkey at Thanksgiving, and everybody passes out. And I think there's more to it. I think there's so much stress built up to and the expectations and families coming over. Maybe it's that one time of the year you see them, or and then finally there and you eat, and it's like, okay, the stress is finally done, and it's still kind of lingering. And then that tryptophan, it's like a double whammy. So you get the tryptophan dose and on top of the come down from all the excitement. And then, yeah, and next you got the hum of the football game going. It's always the Lions and the Cowboys, and a lot of times the Packers play on Thanksgiving too. But anyway, yeah, all that hum, and then everybody's ready for a nap. So that's coming up soon. There's going to be a lot of Zoom Thanksgiving dinners, maybe. I don't know. I don't think we're going to get together with our family, unfortunately. But maybe Christmas time. We've done well up to this point. So I don't know. We'll see what happens. But anyway, you guys good? Autonomic nervous system, right? Pretty fascinating. I'm going to get off of it and show you a couple of things real quickly, and then I do want to discuss a couple of special sensory and general sensory, special sensory stuff. But we do look at the pathways of the parasympathetic first, and again, we notice this is your rest and digest. This is your regulatory pathway. So we primarily see the vagus nerve. I think we saw the vagus nerve last week. The wanderer, cranial nerve number 10, is going to branch off to the heart, to the stomach, to the intestines, to the liver, the pancreas, the kidney. I mean, it goes everywhere, right? So we're going to have that regulatory, keep everything in check, keep everything normal and in balance. And we also see a branch of that coming off toward the back. This would have to do with like your proprioception, some of your posture muscles. So that's we also see the brain kind of having a direct line in that parasympathetic pathway. And then, of course, we're going to see some of the proprioception of your facial muscles involved, as well as a few other basics regarding the digestive system and some of the glands of the mouth or the oral cavity. When we come over to the sympathetic pathway, we do see something a little bit different. We don't have that direct link throughout the body with these organs. We have, so this would be more like your if it's not a digestive organ on the sympathetic side, these are going to relate to more or less kind of being stimulatory or excitatory pathways. So the digestive would be more or less inhibitory pathways of the sympathetic, because again, when we're getting chased by the bear, we don't want our day. We're not thinking about hunger. We're not thinking about using the digestive tract to assimilate nutrients and package waste. That's the least of our concerns. So under stressful situations, we do see the colon, the small intestines, the stomach, even into the esophageal area, in essence, kind of shut down. A lot of the blood actually leaves. We see what's called vasoconstriction occur in a lot of the digestive or gastrointestinal tubing to again get the blood out of these areas and get more blood flowing out to the arm, to the appendages, including the head. So anyway, we do have some shutdown inhibitory mechanisms coming from sympathetic. We have some stimulatory and excitatory mechanisms, particularly dealing with vasodilation and bronchiodilation, you're right, or dilating the respiratory, and certainly, again, getting the heart beating faster. And again, we have that connection with the kidneys. We see a lot of anti-diuretic properties, a lot of retention of water, retention of sodium. We see the adrenal glands involved. So sympathetic it comes off of the spinal cord and what they call these chains. We looked at these sympathetic chains coming off of the spinal cord last week when we looked a little bit at the peripheral nervous system, particularly the spinal nerves. We saw these chains coming off of the spinal cord. So anyway, that is kind of the map of sympathetic and parasympathetic. I do want to, I was going to go back. This is what they call the thoracolumbar division. Okay, thoracolumbar, cervicothoracic division. Okay, thoracolumbar. Okay, and then let's see, there was a couple other things. Again, I don't want to spend too much more time on this because it does start to get into more functional aspects, more chemistry aspects that we see next semester. But I do want to mention a couple that we've heard of, like epinephrine and norepinephrine. These are more of dealing with adrenergic responses, which would relate to being sympathetic. So we would say adrenergic sounds like adrenaline, which you know that adrenaline is going to boost blood pressure, heart rate, respiration, body temperature. These are adrenergic fibers. And then cholinergic, we oftentimes relate to being more of the parasympathetic aspects, and particularly dealing with the neurotransmitter called acetylcholine, or ACH. Again, for right now, it's not super important or imperative that you etch these into any type of long-term memory. However, you have seen these now, and next semester, I mean, you'll see acetylcholine so much from day one through day whatever the last day of the semester is. I mean, it's ACH or acetylcholine is just going to be a term that you know no different than insulin or glucose or water or sodium. Okay, so acetylcholine is a big player in physiology. So this is kind of your introduction, I suppose, then to seeing that term. But it does oftentimes relate then to parasympathetic pathways. And again, a lot of what we're doing is maintaining tone. We need our blood vessel walls to always have those smooth muscles of the blood vessels to maintain some tone, just like we need our skeletal muscles to be able to maintain some sense of tone. It doesn't mean that the muscle is always, in some sort of contracture. It just means that there's always going to be some sort of autonomic input to skeletal muscle, as well as certainly as well as our smooth and cardiac muscle. So if we want to maintain, and this plays a role when we think about blood pressure. When you look at those two numbers, 120 over 80, that bottom number, 80 millimeters of mercury, we're measuring pressure, right? It's blood pressure. So the lower number is the pressure that's maintained inside of that artery between heart contractions or ventricular contractions. So in other words, when the heart contracts, blood is going to fill up the arteries. So your arteries are going to increase in pressure. They're going to increase a little bit in diameter. So in between contractions, so as the ventricles are filling back up, the arteries are slowly kind of relaxing a little bit. They're not completely relaxing. They're not like flattening out into being nothing, and then the heart beats again, and then they expand up to back up to, withstanding 120 millimeters of mercury of pressure. So there's always some sort of resting pressure in an artery. That's what we would call tone. So the sympathetic nervous system is in charge of that. It's also in charge of constricting or dilating these blood vessels, so we can increase the amount of we can increase flow rate or decrease flow rate depending on diameter. Again, that 120 over 80, the 80 implies that we have some sort of a resting tone or pressure involved. And so when we go up to 120, we really are we're going from 80 up to 120. So we see a 40 millimeter of mercury pressure change in against the walls or the linings of these arteries. And so when you guys analyze blood pressure more next semester, one thing we look at is the difference between systolic and diastolic, or the difference between the resting pressure, the bottom number, the diastolic, and then the actual ventricular contraction, the pressure after a ventricular contraction, what we call the systolic number. So that difference should be around 40 millimeters of mercury of pressure. When we get further away from that number, what we end up with is potentially, if I've got 140 over 80, that's 60 millimeters of mercury difference as opposed to 40. So if I'm going from 80 to 120, that doesn't put as much strain on the walls of the arteries as if I go from 80 to 160 constantly. What that does is lead to a potential for an aneurysm forming, and then an aneurysm is a weakened artery wall, and so it's kind of like a hose. When you got a weakness in the outer layer of your hose, and the black kind of lining starts to push through, or there's a weakness in the wall, and that's an aneurysm. And if that bursts, then we've got internal bleeding and a whole slew of problems. So aneurysms oftentimes are the result of, and a burst aneurysm are the result again of chronic stress, right? Chronic tension and hypertension. So good. Yeah. We'll look at the MAP, right? Mean arterial pressure. Good. So in advance, we do some labs that analyze mean arterial pressure. We look at pulse pressure differences, and um, so anyhow, yeah, we got to keep all the tubes ready. That's that autonomic system. So the nervous system, even when you're asleep, right? The heart's still pumping, blood pressure's still there. We've just got a whole slew of stuff going on all the time. It's pretty fascinating, isn't it? It's pretty amazing that the human body is able to withstand so much stress and keep us living to be the ripe old ages into our 80s, 90s, and even into our hundreds. So yeah, it's something to certainly be grateful for, and appreciate every day that you have, because it is truly an amazing gift that we all possess. So anyways, sense organs, again, we think of general senses and special senses, right? So a salute to general senses. We're going to see that particularly getting into the sense of touch, right? You guys all learned about the senses, right? The five senses. That's probably like first grade, maybe kindergarten. I don't know. But you learned about touch and sounds and smells and sights and tastes, right? So general senses, we're just going to look really at like pressure, temperature, even. We're going to look at inflammatory. We're looking at chemical chemical changes being picked up by general senses. We'll look at pain, of course. So general tactile, right, with skin. So when we look at general, we're really thinking primarily of what we would call somatic sensory. So a lot of just your cutaneous receptors, your skin receptors, are going to pick up what we call external factors, right? So external stimuli are picked up by what we call exteroceptors or external receptors. Also, they'll call them cutaneous receptors. Now, we do see different types of nerves with these receptors. Some of the nerves you'll notice are what we call free. So we see free nerve endings. We see them over here. There they are, free nerve endings. And then we see what are called encapsulated nerves. So that's what these corpuscles are encapsulated. Now, uh, do you need to know the different specific names of these nerve endings? I don't know. Maybe again, I guess it kind of depends on how far you're going to go in your field and what type of work you're going to be doing. But I know again, pain and trying to understand the different types of pain. Are they acute? Are they chronic? Are they neither? I mean, we've had tons of patients that come in and we run some very basic kind of physical exams, diagnostic f- tests through physical testing, muscle testing, and we'll do dermatome tests, myotome tests, and there's no indication of anything really going on. And we run blood tests and there's no high levels of some of the histamines and antihistamines and pyrogens. And so so we have to really have a decent understanding of kind of how sensory works. So we have what are called these free nerve endings. They're going to pick up a lot of these are a lot of your pain receptors are going to be free nerve endings. They're going to pick up a lot of inflammatory issues. They're going to pick up some of your broader kind of touch uh, type of things, but they're not free nerve endings are not finite. In other words, we see what's called referred sensory. Sometimes they call it referred pain. Again, when you have a free nerve ending, it's usually they're pain. Most free nerve endings are pain receptors. And so it does make pain tricky to isolate, but it does make pain very loud. So what gets a lot of patients coming to you is the fact that they're in pain. And again, if the pain is really loud, it's their body's way of communicating with the brain, certainly, that something is wrong. And oftentimes it's inflammation that's creating that pain. And um, so that's a good thing about having free nerve endings, is that they do have a tendency to pick up a lot of information. They pick up a lot of stimuli. They're very sensitive to tissue compartment inflammation, and so anyway, the kind of cons, I guess, or one of the downfalls of the free nerve endings is being able to isolate the specific location sometimes of the pain. So we do use special instruments to try to isolate where the pain may be coming from. But you guys have probably all heard of referred pain at some point. And for example, we see oftentimes like gallbladder stones. That's in that right upper quadrant. We'll see patients sometimes complaining of wraparound, sharp, kind of burning pain in the side, even maybe wrapping up in between the shoulder blades. So that's like a referred pain. You see that sometimes if a nerve is impinged, like the sciatic impingement can refer some pain down into the back of the upper leg, or even all the way down into the calf muscles. So referred pain is oftentimes is because these nerve endings are free. They're kind of like wires that have been snipped. So there's still, you can touch that frayed wire, but there's still electricity. If it's live, you can still feel heat and electricity coming off of that fray. So anyway, encapsulated, they're going to be more specific. They're going to deal with what maybe more of your pressure, more direct, I guess, touch type of signals. So pressure, like poking, tickling, those types of things, fuzzy. That's all going to be picked up by more encapsulated nerve endings. Okay, so anyway, exteroceptors, that's what we've just been talking about, primarily thinking of cutaneous. We also have what are called interoceptors or visceroceptors. Viscero means guts, so visceroceptors are located internally. So again, these are going to pick up inflammation that's internal. So if you've got some sort of like if you've got a UTI or something, or if you've got gas or acid reflux or something along those lines, you're going to be getting those pain signals sent via these visceroceptors, and again, also known as interoceptors. Proprioceptors are a similar type of visceroceptor. They're more specific. Again, we've seen this term with skeletal muscles. These help with maintaining posture, maintaining tone, muscle tone, and muscle posture. I'm going to come back to that. Here we go. So this is a proprioception. A couple of the specific components of proprioception, or maintenance of muscle tone and muscles knowledge of where they are in space. So one of these items is called a Golgi tendon organ, a GTO. You can kind of see that there. The Golgi tendon organ, just like it sounds, it's embedded in the tendon, has nothing to do with Golgi apparatus like you've seen with cells. It's just it's Golgi dealing with tendons. This is kind of a wraparound type of group of nerves or bundle of nerves embedded in tendons. And what they do is communicate with the brain what type of the degree of stretchability that the tendon is experiencing. So if a muscle is overly lengthened or overly stretched, the tendon, of course, is going to be overly lengthened or overly stretched. And so the message is going to go to the brain saying, stop, stop, stop. Let's either recruit more muscle fibers, recruit some fixators. Let's get some action going to take the burden off of that specific muscle. So the Golgi tendon organ helps us to not strain a muscle or go overboard, or even detach or rupture a tendon. Ooh, okay, Golgi tendon organ. All right, the other muscle spindles are the other proprioceptor nerves that we see specialized wrapping around muscle fibers. So we do see specialized sensory, and again, we're going to have type 1, your slow twitch, and type 2, fast twitch nerve fibers. Again, spindles wrapping around these individual muscle fibers, again enabling the maintenance of tone, keeping the muscles from completely going flaccid or completely overly contracting, right? Spasming. The opposite of a flaccid muscle is a spastic muscle. So these spindle fibers communicate to the brain, in essence, what type of tone the muscle is maintaining. So, lastly, with receptors, I just want to mention a couple more things, and then we'll move forward a little bit with special senses, and then go from there. We can conclude for that matter. You guys can work on some items together. It's completely up to you, but I do want to just discuss a couple of more things, and then I'll be done. This slide shows the different types of receptors. These are going to be, again, primarily, these could be extero or interoceptors, but these are the primary types of receptors that we do see throughout the body. Mechano, and again, the name tells you a lot about what's going on. So mechanoreceptors are going to deal with mechanical stimuli, with some sort of movements that may be going on with the cells, tissues, and organs. So we would probably see mechanoreceptors dealing a lot with muscle, right? Skeletal muscle. Chemoreceptors deal with chemicals. So we may see these when we're talking about axon terminals and neurotransmitters and synapses. And so a lot of, again, advanced A&P gets into chemo receptors, especially acetylcholine or ACH that we saw a few minutes ago. Thermo, of course, are temperature receptors. We'll skip the next, that no see, we'll skip that for now, come right back to it. Photo, of course, has to do with light. So we would see photoreceptors primarily dealing with the eyeballs. And then osmoreceptors deal with osmotic balance, which in essence is fluid and electrolyte balance. So the organs that do a lot of work to maintain fluid balance would have more osmoreceptors than organs that maybe don't do as much work regarding fluid maintenance. So like the kidneys would probably, and generally just your cardiovascular system, and as it works with the kidneys, including the lymphatic system, these are going to be osmoreceptor hotbeds. All right, nociceptors. So we skip nociceptors. Nocio means pain. So these are going to be pain receptors. That may be the only term on there that's a little bit new or a little bit odd. So nociceptors, again, I mentioned those are going to be those free nerve endings. They're the most widely distributed. We also have temperature picked up by free nerve endings, which again is good. The free nerve endings, remember, they branch out. They're able to pick up and receive a lot of information. And then the encapsulated, we're dealing more with itch, tickle, what we call discriminative touch. So more direct touch. And again, I don't know if it's necessary for you to know the specifics, tactile and lamellar. I don't think it is. You've got plenty to do. All right, special senses. We're going to zoom through this. This is a fast-paced action. We're putting the pedal to the metal. We're rounding. We're probably actually round. No, we're rounding third. I was going to say we're rounding second, but that doesn't sound very appealing. That is scoring position though, so we'll say we're rounding third. Olfactory, quick. That just deals with smell, right? We know that already. We see the olfactory bulb, cranial nerve number 1, kind of nestling right in that ethmoid bone, that cribriform plate, and then we can see we've got little olfactory nerve extensions or fibers sitting right at the roof of the nasal cavity. Okay. Olfactory pathways, we looked at these last time, right? Remember the limbic system. We saw olfactory comes in and travels through that amygdala and hippocampus, and we end up kind of over here in the temporal lobe. Takes us into taste buds. We've got a fancy word for taste, and that's gustatory. So fancy word for smell is olfactory. Fancy word for taste is gustatory. So we see that ori part again. And then we do have little bumps called papillae located, and you probably have seen these on your tongue. They're called papillae, 4 different types, fungiform or fungiform. These are going to look like little mushrooms or toadstools. Circumvallate, they're going to look just like you guessed it, they're going to look circular, kind of like cylinders. These are going to look a lot like kind of fat pop cans. Foliate, these are going to look like little tree leaves. And then filiform, these are going to be tiny little, very small, uh, uh, almost like cilia. So filiform kind of sounds like the word cilia. So these are going to be skinnier, almost like little hair follicles. um, yeah, we're gonna keep her moving. Pop cans, you're yeah, it's not soda, right? Soda cans. Yep, that's a big one. Pop, it was pop, right? Growing up in Illinois. Yeah. When I lived out west, it was soda. So I said soda a lot for a while. If you're down south, it's Coke. Everything's Coke. Right. Well, Coca-Cola is out of Atlanta. So, if you want Sprite, you order Coke, I think. Anyway, pop is Coke down south. That's weird too. But yeah, pop is soda. Yeah, soda. Yeah. Uh-huh. Pop is grandpa, right? And soda is pop. Pop, yeah. Yeah, pop. There's a map. If you Google, somebody did a study on this, of course. Sociologists like to study this type of things, these regional dialects and that. So if you look up soda versus pop, you'll find a map of the United States, and it has kind of the regions, and it's kind of like the electoral college map. Red and blue. It's Coke and Pepsi, and it's pop and soda. So anyway, there are a few others too. But yeah, if you look that up, you find that map. It's kind of cool. It says kind of breaks down the percentages and what regions say what. But yep. So some say soda pop. They just cover both. They cover all the bases. Then nobody's, then they can't tell where you're from. Right, from Mars. So anyway, foliate, filiform, fungiform, these create little kind of dips or depressions, and within these dips or crevices are where you find the taste buds. So in your little in on your tongue are all these little grooves, and they're called crypts, like Tales from the Crypt. Okay, these are little taste crypts, and then down in here, you're going to have a pore, and all of those those food molecules, they go right down and they get picked up by this little onion looking deal, and then these gustatory cells and the taste fibers. It's primarily the facial nerve and glossopharyngeal are the two cranial nerves that pick up taste. And you guys remember learning probably about four. When I was a kid, we only learned about four tastes. Oh, here's those, by the way, micro view of the tongue. Here's the filiform, right? They kind of look like cilia. And then these are the mushrooms or the toadstool, kind of the fungiform. But yeah, remember this kind of deal. They showed us a map, right, of the tongue, and all of those different moved here from California. Someone to the time machine. People were lunatics. Yeah, well, we are lunatics in the Midwest. You got to be hardy, right, to live here. Or maybe Californians. They're the lunatics. So from what I hear, all right, they call that the left coast, not the West Coast, but um, they're left-handed for sure. Uh, I hope I'm not offending left-handers or left anything, but I'm just saying. I never lived in California, but I lived in Oregon and I lived in Washington. Not a far cry from California, I'll tell you that. But I did travel to California several times, and yeah, that's a different world. Texas too. I've never been there, but I know those are two states that they beat to their own drum for sure. But yeah, you got to be hardy, right, to live around here. We've got four dramatic seasonal changes, and yeah, if you can't take the heat, if you can't take the cold, man, this is not for you. So yeah, us hardy Midwesterners. uh so anyway, bitter, salty, sweet, and sour, right? Those are the big four. They've added a fifth one called umami. You've maybe heard of glutamates, right? Like so MSG. A lot of Asian restaurant menus will say no MSG, or we can prepare it with no MSG, stuff like that. That's monosodium glutamate. You can find this at the grocery store, not umami. You can find MSG. They call it accent. So if you got a bottle of accent seasoning in your cupboard, that's straight MSG, monosodium glutamate. Some people have umami sensitivities and they get migraines from MSG. So that's why a lot of restaurants will put that on packaging, no or food labeling, no MSG, because again, it does give some folks headaches. Glutamates, I don't know, I think like tomatoes would probably have glutamates in them. I'm not 100% um, sure. I think so though. Oh, hard to say. Like sometimes they'll get irritated, like it's like an inflammatory response to irritation, whether it's a seasoning, whether it's heat, like actual temperature, not heat, not like cayenne heat, which could also do it, right? Something irritated it. Could be a toothbrush, an acute thing, could be a bite, you bit, but yeah, if it's in a child, it's good. They're gonna probably outgrow it. Kids oftentimes, from kids' tastes are really strange. From 0 to about 3, they have nothing but really sweet. Sweet is that purple one. That's kind of their loud, so they really like sweets. And that, right? Kids love sweets. Don't give the baby honey though till they're probably like maybe a year and a half old. But once they transition to being like like K, like 3, 4, 5 age, they're starting to establish these guys here. So they're sometimes they'll go on kind of like a hunger. They don't want to eat what we do oftentimes, and it's okay. They outgrow that. And sometimes during that growth spurt, they'll get they'll get some inflammation. Some babies will get inflamed taste buds due to the suckling. Like sometimes that can create that. So anyway, yeah, usually it goes away and they outgrow it. Now, in an adult, if it's not going away and if it becomes a problem, if it's getting bigger, we need to check that, because I mean, I don't, not gloom and doom style, but you know as you know, when there's something there that's not going away, and maybe it's painful, maybe it's getting bigger, that could be something that needs to be checked. So yeah, the tongue. Let's see, external and taste. So taste and smell always go together. Now the ear, we see kind of two senses, right? The sense of sound, right, hearing, and then we talk a little bit about balance. We look at the external ear has two divisions, kind of the what you see, well, what you see with an ear, and then certainly then the kind of where you put the Q-tip. I don't know if you use Q-tips. They say you're not supposed to, but I don't know how. I mean, what are you gonna do? There are these cool little kind of plastic scoops. I don't know if you've seen those. They're real. They look like a Q-tip, but they're plastic, and they're fairly pliable. One end, it looks like the shape of a Q-tip. So it got a bunch of ridges, but the other end looks like a real tiny little spoon or scooper. And so you could put that in there and scoop wax out. I've used those on my 7-year-old. She gets kind of wax bill for whatever reason. I don't know. I do know why. I think it's on chromosome number 16. There's a earwax spot for dry or wet earwax, and so she got the dry one, so it'll just kind of like impact in, like my other daughter has more wet earwax, so easy. You know what I'm saying, right? So I have to get in there and like scoop it. And I know you can't use a Q-tip because it's just gonna push stuff in there. So yeah, I found these little scoopers, and yeah, you can go right in. Let me see. Here we go. So you can, yeah, you go right in here and just, and you know, you put a light, shine a light right in there, and you're like, whoa, it's a kind of brownish, greenish, yellowish goop. You go in there and you pull that out. And notice too, there's a little depression here, so you can get kind of down in there. A Q-tip's just not going to do that. In fact, a lot of times the Q-tip's kind of pushing stuff down into this area. So you're really only kind of getting this. So those scoops can really help to get in some areas. Some people irrigate their ears with I don't know. You got to be a trooper to do that, or to have that done. But I mean, I guess if you got a lot of wax buildup, that certainly can help. Never put, the ears are very sensitive. Never put cold or hot. It's got to be room temperature water. Or if you're using, some people use peroxide, you know, they'll get the little kind of ear syringe and put hydrogen peroxide. Even room temperature peroxide is a little too cold. It can, if you squirt something into the ear that's really hot, not even, doesn't even have to be really hot or really cold, it can send the person into some serious fits. So but it could cause you to puke. It could cause some dizziness, and so anyway, yeah, just squirting ice cold or super hot into the ear can mess you up. So be careful with if you're doing it. So, some of you maybe, or all of you, have you heard of ear candling? I mean, I don't. That gets into the like the white lighter kind of the new agey group, but I know some people do ear candling. They sell, I mean, get them on Amazon. They've got to be good, right? Yeah, Walmart maybe.com. So it's got to be okay if they sell those. But I know some, I've had it done. I figured, why not? I'll try anything. So, oh, Brittany, I will have fun. Um, Thanks for coming in. I'll see you on Thursday. Lori gets it for artificial sweeteners. Possibly, artificial sweeteners can cause, yeah, definitely. That could be related to that umami. It could be too related to the sweet. Artificial sweeteners are oftentimes 300 to 600 times sweeter than regular sugar, cane sugar. So that could be enough to trigger like a hyper responsive sweet response. That's enough to like, give you a little bit of a headache too. Yeah, artificial sweeteners should be avoided at all costs. If you don't know how to get off of that, or if that's a bad deal. Anything with diet or sugar free, man, some of them hide it too. You got to look on labels. If it says aspartame or sucralose, you better run, or throw it in the garbage. You don't want it. It's bad for you. It causes all kinds of problems, and it definitely is addictive. So it has properties that you would not believe. The aspartame it comes from something. It comes from E. coli, so it's not even. It's like E. coli poop. There's a Futurama. You should look. There's a good Futurama episode. Slurm. It's a drink that gets produced, and Slurm. Futurama is like a Simpsons Matt Groening created thing, but it's pretty cool. There's one episode on Slurm, Slurm. It's like Mountain Dew, super sweet, but they go underground, and they go to the Slurm factory, and yeah, it's these big giant E. coli looking worms, and like things hooked up to them, and their little teats, and they're pulling sugars out of them, and that's how. Anyway, so yeah, be careful with artificial sweeteners, dudes. Oh man, yeah, avoid it if you can. You're better off going without. You're better off drinking a Coke than a Diet Coke. Trust me on it. You're better off not drinking either of them. But if you got to choose, you're not getting skinnier by drinking Diet Coke. I'll put it that way. Um, Diet is a scam. It's not it's not hidden. It's not a big secret either. So anyway, that's your external ear. Middle ear, malleus, incus, and stapes. These are three tiny ear bones. They also call them hammer, anvil, and stirrup. That's really all that makes up the middle ear. There's a kind of a eustachian tube, they call it. They also refer to it as an auditory tube. Some of you've maybe had tubes in your ears or have heard of that. This is where they're putting it, the auditory tube. So basically, sound comes in, right, and it kind of in waves, and all of these little grooves and valleys and depressions. They funnel all of those sound waves into this EAM here, and then the sound waves vibrate. That tympanic membrane, which then vibrates the malleus, incus, and stapes. So all these sound waves are ultimately going to end up over here in the vestibule, kind of the entryway, like a vestibule's, yeah, that area when you walk into a Target and or Walmart and you're not in the store, but you're in the building. That's the vestibule. They have like the claw machines sometimes in the red box in there. That's the vestibule. Okay, so that's where all those sound waves go. And in the meantime, we've got this round window here. So the sound waves are going to travel down into the cochlea, and this round window and the auditory tube, they kind of helped with keeping sound so it's not so muffled. These allow sound to resonate. So when auditory tubes are inflamed, and the tonsils are down here, the auditory tubes open up. They're called into what they call gill slits, pharyngeal gill slits. Sounds fun, right? Yeah, we're living in water, right? In the womb, we're fish. So, but anyway, your tonsils, right, and your adenoids, that whole area in the back of your throat, that's where this auditory tube kind of opens up into like a little tiny slit. And so if you've got infection in the throat, tonsillitis or something, that can work its way up into the auditory tube. It could close that up. You could get, this is if the tonsil's inflamed, it can just cause the end of the tube to close. And so it sounds like you're underwater. Everything sounds underwater. Sometimes these will get inflamed, right? They hurt. Oh man, it burns, right? They got an infection. You might have like a middle ear or an inner ear infection. Okay, if that becomes like a chronic issue, the doctors will oftentimes say, well, we can remove the tonsils, remove the adenoids, and put tubes in the ears. Or we can just put tubes in the ears. Or, we're tired of giving you antibiotics, and he or she, they keep coming in, right? So anyway, that's what they'll make a tiny incision usually right in here, and then they'll just pop a tube right down in there, and then they might outgrow it, and they might push it out. It might push out down into the back of the throat, and so anyway, that's what tubes in the ears are, and sometimes they're good, sometimes they're not, sometimes they help, sometimes they don't, sometimes you outgrow the constant infection. Sometimes it's a dietary problem. It's a environmental issue. They could be around pets. They could be around a lot of dander. They could be around a lot of allergens. They could be consuming a lot of allergens, so it's clogging up this. So now they're breathing through their mouth all the time, and so the tonsils in the throat, they just get inflamed because remember, you're supposed to be breathing through the nasal cavity, so you can allow those cilia, goblet cells, sinuses to kind of do a lot of the work. And if you close all this up and now all you have is a mouth to do your breathing with, man, that does a number on the tonsils and adenoids and the larynx and the pharynx and the back of the tongue. And pretty soon you've got, some chronic issues. So if kids are coming in, and they do, I mean, shit, they come in constantly with ear infections and tonsils, and they give them a spritz antibiotic, and they back out the door, and then they're back in, and we never get into like anything, right? So we're fine, but again, doctors are getting dinged more for these repeat visits, so they're more quick to jump on well, let's take out the tonsils, let's put the tubes in. They used to wait. They'd say, well, the kid will outgrow it. Try these things, try not doing this, try doing different, whatever. They'll outgrow it. And others will jump right in and say, nope, if you remove a tonsil and your tonsils, remove adenoids, they can't get tonsillitis or adenoiditis. So that's a plus, right? But lack of a tube in the ear isn't why you have ear infections. Um, Lack of removing the tonsils isn't why you have tonsillitis. So there are other factors in play than just removal and treating symptoms. So but that's the triad of tear, man. It's an insurance slam dunk too. They ask you what your insurance is, and you've got the Platinum Premier, man. They've got you on the table. They've already made the appointment. In fact, they probably have already got you measured out for the tube, and they're ready to start getting to work. So be careful with that. You don't need to go under the knife all the time, and your kids certainly don't. But you don't want your kids to get accustomed to having doctors healing them. We say practicing their medicine on them. Your kids aren't guinea pigs for the establishment. They're not a game. It's not a sport. It's not something that they should be viewed as some sort of pincushion for practice. So anyway, we do have a couple of other items too, right? We've got the inner ear where this cochlea, this is where all that sound is going to go. So these sound waves get picked up and distributed through this cochlear nerve. And then we have these, and we talked about these a little bit last week, these semicircular canals, because we talked about the vestibulocochlear nerve. These are the semicircular canals that help with equilibrium. These are, in essence, kind of hollow tubes lined with little cilia. So I'm going to pull those up so you can see those. It's crazy. These semicircular canals, um, they have so what we've done, we've kind of cut open and shown you kind of the inside of the macula, and then we'll look at the utricle too. But inside, we're going to have what are called, and in these semicircular canals, we'll look at both. We have what are called otoliths. Oto means ear, lith means stone. So you have little stones in your ears, and these stones are suspended in a gelatinous matrix, and this little matrix, again, it's kind of like it's like jello. So you've got jello with little chunks of fruit in there made of stone, so seeds, I guess, and they move around every time you move your head forward and backwards. These little buggers kind of move around with them, and as they do, they're flicking these little cilia, uh, and these cilia uh, come down, and they connect right to these vestibular nerves, and so the nerves are picking up direction and balance. So when you lean your head forward, these little jello molds, they kind of move forward too, and they trigger these cilia send signals to your brain that that's the direction you're facing. So there you go. So we've got upright and then bending over. That's in the macula, and then we look at more in what we call the ampulla. An ampulla is kind of like a little puffy, kind of like a pouch. So as we enter the semicircular canals, we have another kind of a specialized mechanism called the crista ampullaris, that this has to do more with spinning. So so anyway, so when you're spinning or moving your heads, rotation of the head or the neck is going to cause that to move different directions and signal to your brain that that's the direction you're moving. Yeah. All right. So let's see. We're almost done. Eyeballs are next. Let's look a little bit with vision. We've got the basics that you probably already have heard of, right? The colors of the eyes are called the iris, and then the circle in the middle there we call the pupil. That's really an opening that goes into the back of the eye and allows light to hit the retina and get picked up by all of those specialized rods and cones. Okay, we've got kind of the inner and outer or medial and lateral corners. They're called canthus or acanthus, lateral canthus and medial canthus, or inner and outer. Oh, and the whites of the eye they call sclera. Okay, the sclera is the whites of the eye. Now, as I transition to the next slide, the sclera is kind of the outermost layer. The eyeball is three layers, and the most superficial layer is called the sclera, which you know that's the white of the eye. But then, as we go over top of the iris and the pupil, we have what's called the cornea. So the cornea is kind of an extension of the sclera. So you can see that a little bit here. So this is that outer layer called the sclera. Let me get my pointer going. Yeah, there we go. The brighter. So you can see this outer white layer is the sclera, and then we see the cornea is kind of like a little, almost like a contact lens. It's a clear kind of a dome that sits over top of the iris and pupil. Okay, so the cornea, and it just continues and it's to being part of the sclera. We also have what's called the conjunctiva or conjunctiva, which is going to be kind of like a layer, a filmy layer that's kind of connected with your eye, with kind of like the insides of your eyelids. So your eyelids are going to have kind of this extra layer called the conjunctiva, and that conjunctiva or conjunctiva that can get irritated or inflamed and lead to what they call pink eye. So conjunctivitis is the, I guess, sciency term for it or medical term. Pink eye, right? That's what we know it as. Pink eye could be just an acute, you could get something in your eye and irritate the you could irritate the cornea, the sclera, the hopefully you don't scratch the cornea, but you can certainly irritate, and that could cause the conjunctiva to be irritated and inflamed. So but oftentimes it's due to some sort of bacteria that you know, daycare, right? Kids are putting fingers in places they shouldn't, and then not washing it, the limited hygiene practice at daycare. So even if they tell you there really isn't. And so pink eye, that began. Then there's that other one, was it foot and mouth and hand and butt and whatever? Ugh, right? Yucko. So yeah, they're kind of handsy. They got the Joe Biden handsy deal going. So yeah, you could get a fingernail. I got it from my kids. Oh yeah. Oh, classic. You know, only with kids, right, Stephanie? Yeah, but before PK, right? Pre-kids, life was just nothing but roses, and then kids, right? And then it's pink eye and the shits and the snots and the pukes and the lack of sleeps and everything else's, right? Ooh, I hear you. That's a doozy, though. That's a good one. A fingernail that got drooled on, landing in your eye. Yep, that'll do it. Doesn't take much, right? So yeah. Let's see. Oh, the other thing I want you guys to kind of see here, and we'll look at it again in a second, but there's kind of like a little cavity. We call it an anterior cavity right in here. It's filled with fluid. They call it aqueous fluid or aqueous humor. But this is the anterior cavity of the eye. You could see the lens is kind of the dividing wall. So if we go just through the pupil, just past the iris, we end up at the lens. So this whole area is kind of like a compartment that's filled with a clear fluid. Okay. As we travel back, now notice too, if we look at the iris, it's kind of got a pink color in this section that we see, and then we notice there's a little bit more pink here, and then some little kind of strings dangling off, and then we go a little further. This is what they call the choroid layer, and we'll see this term in black and white in just a second. But this is one of the better kind of shots of it. But this choroid layer, that's where a lot of blood vessels are located. It's also kind of the muscular layer. The iris really is kind of like a glorified type of or specialized type of muscle. And of course, it does have pigment with it too, right? That gives you the blue or the brown or the hazel or the green or whatever color of irises that you have. But that's based again on genetics and your code. But this choroid layer, notice it has these little they're called ciliary muscles, and we'll see that coming up too. But these kind of these are suspensory ligaments that hold that lens in place. And so when I'm trying to when an image is coming in and I'm trying to focus on it, that's where the lenses are going to play a role. So these little puppet strings are going to either kind of constrict a little bit. Maybe they're going to pull and flatten the lens out. That will enable you to see something far away. If we need to see something up close, we need to adjust the tension of these little cords and allow the lens to be maybe a little bit more curved. Um, so that's what you're doing when you guys are focusing. Your ciliary muscles are contracting or relaxing and adjusting the shape of your lens. Now, those of us who wear glasses, um, our eye shape is maybe a little bit different, and so I'm nearsighted, so my lens is always pretty concave or it's pretty curved. And so that curvature of my lens, so if I take my glasses off, I can see really clearly up close, but I can't, everything outside of there is blurry outside of like an inch, probably. I have really horrible eyes, so I must have a really curvy lens. So what that may mean is my eyeball shape is kind of like a football laying on its side. So it's kind of like if you smashed it. So the eyeball's been kind of smashed. So it's elongated. And what that did is it kind of elongates the lens. Now, why does this have so farsightedness would be the opposite. It'd be like a football on a tee. So it'd be the eyeballs more this way. So the lens is more elongated this way. So now, what would cause all of this? Some of it certainly is heredity and genetics and that, but the eyeball shape itself is in essence dictated by these extrinsic eye muscles. So you could see the eye orbit, right? Kind of the socket that the eyeball sits in has several muscles also attached to it, and there's several. These are just a couple. As you can see, I don't know, probably 12 per eye anyway. And so if any of these are excessively pulled or excessively shortened or excessively lengthened in some way or another, you can envision how if I pull this one and pull this other one, how it would stretch the eyeball maybe this way a little bit. Whereas these top ones, if I pulled on those or shortened those, it may stretch the eyeball more this way. So there's something to be, and then you know the optic nerve is also associated with that. So what you don't see if we cut this is the actual eyeball itself has the nerve continues, and that's going to eventually cross around the pituitary gland. But my point is, shape of the eyeball, position of the eyeball is oftentimes dependent on the shape of the eye orbit, the positioning and shape and structure of the extrinsic eye muscles. So sometimes we're just happy we're in the 21st century and that we have glasses and other corrective lenses. Man, if I was alive 500 years ago, or oh, I would have been stuck sitting in a room putting like, I don't know, beads on strings or so. I would have been useless because I've had crappy eyes since I was like 6 or 7. I don't know. I don't know what happened. What do you do? Take me out to pasture? I mean, I'm useless without glasses. Well, anyway, hopefully I never have to worry about it. So anyway, lacrimal gland. We do have that tear gland. It's like a big shower head that's spraying and lubricating your eye almost constantly. And then you've got these little kind of drainage tubes that we've talked about before in that lacrimal duct, and so on and so forth. So a couple other things I wanted to discuss real quick. Oh, so finally, then, so you have the sclera and that outer layer, and then the choroid, kind of that middle layer. There it is, choroid. That's the vascular layer, a lot of blood supply. This is where, again, you're going to see that ciliary body that's going to be connected to your lenses, those suspensory ligaments that encourage the lens to change shape when you're trying to focus. Then finally, the deepest layer, the inner layer of the eyeball, it is incomplete because, again, it starts, it kind of ends at the toward the anterior aspect of the eye. um there we go. So there's no retina up in this area, so it is incomplete. That's all that means. I think that probably goes without saying. Okay. A couple key features of the retina. This is where we're going to find the nervous system attached. We're going to see what are called rods and cones. These rods and cones are going to pick up different vibrations of light waves. So rods are going to pick up more of your subtle, kind of darker tones, maybe shades, I should say, like your sepia tones and your dark, like your blacks and whites and grays. And cones are going to be more specific to picking up color. So here's a rod and here's a cone. So cones do color. CO for cone and CO for color. Okay, rods and cones. And when we look through the pupil with our ophthalmoscope, what we're going to see is kind of the light reflecting off of the back of the eyeball, off of the retina. And so we see what they call an optic disc. This is where we find a whole bunch of blood supply and blood flow coming in. And that's really kind of what we're looking for. One of the things we're looking for when we do look in the eyes, we want to hopefully see nice blood flow with these retinal blood vessels, because if we do see some issues with blood flow, that can lead to macular degeneration, which leads to blindness. So all of your visuals are going to load up and kind of come together at this macula, and then we're going to send it all through the optic nerve. Yeah, so we talk a little bit about um, the functionality of the special senses more next semester. Again, I just wanted to introduce you to some of the structural features of these special sensory organs. So here again, we have this aqueous humor, this anterior chamber, and then in the back, we have the posterior chamber called the vitreous humor or vitreous cavity. Vitreous implies that we've got more of a gelatinous, maybe a thicker kind of a fluid in there. It's going to help the eyeball retain a lot of its shape. And then out here, aqueous implies that here's that word aqueous, that we're going to have more of a clear liquid that we would see through. So anyway, that's what's going on there. Ba-ba-ba-ba-ba-ba-da. That's it. I don't have anything else for you. That's a lot of info. You guys, I thought I was going to be shorter. Geez Louise, that took almost 2 hours. So Well, time is relative, right? Short for some is long for others. But regardless, I think you guys all got some really good info tonight. So I'm gonna close out there. My brain hurts too, Lori. So I'm gonna call it a night. And I'll tell you, Thursday, you guys are gonna. I'll give you some direction, of course. But come Thursday, be prepared. To be in your breakout pairs or groups. So again, if you use laptops, it's probably going to be easier than using your cell phone. You can use both. You can have a couple of things going at the same time. But Thursday, when you come in, and you can come Thursday during the day too, if you want. That you can come both times for that matter. There's plenty for you to do if and again, by working on these portfolio slash lab assignments together, and by doing any of these review questions together, what it does is it enables you to lighten your load a little bit. So again, the Thursday group during the day, pardon me, they're going to be working on, they actually did 7B today, and then they're going to be working on all of the questions for the exam. So